Hello, my name is Daniel Ontaneda. Today I will be presenting multiple sclerosis highlights, report, and best practices, highlights from the 2016 ECTRIMS meetings. I will be talking on what's new in MRI imaging for multiple sclerosis. My name is Daniel Ontaneda. I am a staff neurologist at the Cleveland Clinic Mellen Center for Multiple Sclerosis. I wanted to cover a couple of studies that I found interesting among all the imaging abstracts that were presented at ECTRIMS. There is a lot of valuable and useful information, and I had to kind of skim down onto the ones that I probably thought were most important and maybe most relevant. Some of them you might agree with me, some of them you might not, so we'll give it a shot. So the first abstract I wanted to discuss was presentation A60, which was MRI criteria for diagnosing multiple sclerosis using cortical lesions. This was presented on behalf of the MAGNIMS group by Dr. Preziosa in Milan. Essentially what this study did is they looked at 72 patients with clinically isolated syndrome, which were studied at 5 different centers across Europe. They used double inversion recovery, or DIR, to examine the inclusion of cortical lesions to the imaging criteria for multiple sclerosis. What the authors found was that 65 of 73 patients developed MS over follow-up over a 24.2-month period. Double inversion recovery increased the number of patients diagnosed with MS, and the addition of cortical lesions to MS criteria actually increases the specificity with preservation of sensitivity and accuracy in a cohort of CIS patients. So essentially what this research shows us is that cortical lesions can be used to diagnose MS early, and it calls the question the need for double inversion recovery imaging in clinical scans. And as we know, this has already been the suggestion of using cortical lesions has already been incorporated to the MAGNIMS MRI criteria, and with the revised diagnostic criteria that are likely to be published next year, these may make it into the new diagnostic criteria. Therefore, it will be a clinically relevant topic for clinicians. The second set of abstracts I wanted to discuss were on behalf of a new group called the North American Imaging in Multiple Sclerosis Collaborative. This is a group that was formed several years ago that essentially is trying to harmonize MRI across North America and create a multidisciplinary, multi-effort group to forward imaging research in North America within multiple sclerosis. I thought these groups of abstracts were interesting because basically what they were trying to do was look at a standardized quantitative imaging protocol for the different MS NAIMS sites. This was presented as several different abstracts, posters 1036, 1049, 1053, 1061, all at the ECTRIMS 2016 meeting. Essentially what they did is they took a single patient who had stable relapsing remitting MS and imaged them at 7 North American sites with a standardized imaging protocol. There were 2 sessions at each site, and then the subject traveled to the different sites. And they looked at several different outcomes. First, they looked at MTR, and they found that the mean intra-session MTR variance was relatively low, 0.001. They found that T1 mapping showed inconsistencies overall due to B1 inhomogeneity. They found that diffusion measurements showed actually good agreement across all sessions and sites, and this was a multi-band form of diffusion. They found that multi-band resting state fMRI showed very poor intersite agreement. And they also found that systematic differences resulting in major biases in volumetric analysis. So essentially, trying to put all these results together, what I would say is that this was a multi-center study with an N of 1, and this kind of highlights how studies with an N of 1 can be valuable, provides very valuable information on measures that appear to have good agreement, such as diffusion, and measures where agreement was not as good, fMRI volumetric analysis, for multi-center applications. This information will be used going forward to better standardize the MRIs and also to understand which methods can be applied with more ease in a multi-center fashion. Next, I wanted to discuss this abstract, which was imaging signatures for multiple sclerosis phenotypes in gray matter. This was a platform presentation by Eshagi from the group in London. And basically what they were doing was trying to explore the spatial pattern of regional gray matter in different MS phenotypes. It was a very large study that included 1,214 MS patients, 203 controls, and a total of 3,604 scans from several different European sites. The median follow-up for this study was 2.8 years. They looked at gray matter atrophy, both cortical and deep, which was greater in progressive forms of multiple sclerosis. They also found that the rate of atrophy was fastest in deep gray matter among all the different phenotypes of the disease. And they also found that the atrophy in deep gray matter was correlated with Expanded Disability Status Scale, or EDSS. So what this shows us is that progressive patients appear to have greater gray matter atrophy, and that deep gray matter appears to be mostly affected and is a driver of disability in MS. These are results that have been presented previously, or have been suggested previously by other groups, but this is probably one of the largest studies that convincingly shows the importance of deep gray matter structures in the pathophysiology and accumulation of disability in multiple sclerosis. Next, I want to cover some OCT imaging results. This was a presentation also called Retinal Imaging Measures Predict 10-Year Disability in Multiple Sclerosis. It was presented by Dr. Rothman on behalf of the group at Johns Hopkins in Baltimore. So this was an observational study of MS patients with OCT at baseline that were followed for a very long period of time. They were followed over 10 years with EDSS as the primary outcome at the end of those 10 years. They studied a large group of patients, 75 relapsing remitting, 9 secondary progressive, and 5 primary progressive. They found that 41% of the RRMS patients and 44% of the secondary progressive MS patients had a previous episode of optic neuritis. And their main study results was that the mean total macular volumes predicted the Expanded Disability Status Scale follow-up at 9.3 years. They conclude that a 1 millimeter lower total macular volume predicts a change in 2 of the EDSS in follow-up. Interesting, the authors also found that retinal nerve fiber layer thickness did not seem to predict EDSS, at least in this study. So we can conclude that OCT is a useful predictor of long-term clinical function, that total macular volume was a good predictor, while retinal nerve fiber layer thickness did not predict EDSS. These results confirm the notion that we can use the visual system as a predictive of overall brain and spinal cord injury. And it should be noted that the technology of OCT that we used in this study was an older technology because it is a 10-year follow-up study. So we might find new results as we have 10-year follow-up on the second-generation OCT machines. This study by Lin et al. From Buffalo was an interesting study to me because it was looking at Nucleus Specific Changes in Thalamic Resting State functional MRI. So I think as our knowledge increases in deep gray matter understanding, as we talked about in the slide prior to last, we're understanding that gray matter atrophy is important, and the deep gray matter atrophy isn't just a single nucleus, given there's several nucleuses, and even within those different areas, for example, the thalamus, one can subdivide the thalamus into different groups. So this study was actually looking precisely at that. So it was a cross-sectional study, 64 MS subjects and 26 age and gender match controls, where they wanted to look at topographic differences in functional connectivity in the different thalamic subnuclei. So functional connectivity was examined in 4 separate regions in the thalamus: anterior, posterior, medial, and lateral. And the results showed that there was a nucleus-specific manner of correlation with the different changes, with the functional connectivity. Thalamic changes correlated with cortical and subcortical regions as a whole, and functional connectivity was decreased between the medial thalamus and the left angular gyrus, between the left posterior thalamus and the left supramarginal gyrus, and the right medial thalamic and bilateral caudate nucleus. So what this shows us is that the thalamus is an important structure, and where the thalamus connects in the different substructures is also of importance. And these authors very elegantly showed this using functional connectivity. So our conclusions are that thalamic substructures have a distinct pathological implications and will likely correlate with a variety of clinical manifestations. And we think that the ability to look at these changes at 7T will be even more informative because the resolution, certainly in the identification of the nucleus, will be much easier. That is all for the presentation of ECTRIMS 2016 updates on imaging in multiple sclerosis. Thank you so much for your attention.